Good morning on the West Coast and good afternoon on the East Coast. Again, I am Larry Harlamus, the Deputy Director of the Quality Division within the Office of Quality Improvement within the Bureau of Primary Health Care here at the Health Resources and Services Administration, otherwise referred to as HRSA. Next slide, please. It's a pleasure to make some introductory remarks today. We are grateful to have the Clinician Consultation Center prepare this webinar today on such a very important topic. The Bureau is committed to leveraging our strategic partners and delivering latest information and promising practices in supporting the work performed at our over 1,400 health centers. Before I turn it over to our presenter, I'd like to share some information about our health center program. As you can see on the slide, in 2018, our health centers served more than 28 million people across the United States. That is 1 in 12 people in the US, 1 in 9 children, 1 in 5 rural residents, and 1 in 3 living in poverty. Health centers provide affordable, comprehensive, quality, patient-centered care through a range of services. Our mission is rooted in increasing access for vulnerable and underserved populations. Among the 28 million patients served by our health centers, more than 385,000 were veterans, more than 800,000 patients access care at school-based health centers. Additionally, nearly 4.5 million are public housing patients, and nearly 1 million were agricultural workers. Next slide, please. This slide shows the commitment the Bureau has made to invest in addressing substance use disorder and behavioral health care services at our health centers. HRSA has awarded over $900 million to support these services in health centers. More recently, in 2018, HRSA awarded $350 million to over 1,200 health centers to increase access to quality substance use disorder and mental health services. The Integrated Behavioral Health Services Supplement funding in 2019 awarded $200 million to, again, over 1,200 health center organizations to expand substance use disorder and mental health services. Next slide, please. And lastly, please note that the information provided today is intended as guidance to be used consistent with the internal needs of your organization. It's not to be viewed as required by the Health Resources and Services Administration, but we do hope you find it useful in supporting your health center's operation and addressing this important topic. I'll now turn it back over to Brenda, who will introduce our guest speaker. Thank you.
Good afternoon, everybody. This is James Gasper, and I will be covering the topic at hand, which is the treatment of mood and anxiety disorders in patients with opioid addiction. And this really is the final frontier. I believe we have good options for the treatment of opioid addiction. They're very effective, but something that I always hear is when patients get into treatment, they say to me, I didn't get sober to feel this way. And it's because there's a lot of persistent psychiatric illness that remains untreated after we address their opioid addiction. So that's what we want to cover today. Our main objectives are to describe the comorbidity, in particular, the impact of opioid use disorder treatment on comorbid mood and anxiety disorders, as well as the underlying substance use disorder. We will talk about the evidence. I'll tell you up front that there's very little, but we'll go over what's been completed. And then hopefully the takeaway from this will be some clinical pearls of taking that evidence and putting it together, and we'll discuss a case at the end. So let's dive in. So psychiatric comorbidity is common in patients with opioid use disorder. This is a study looking at individuals who were referred from a needle exchange site to a methadone clinic, and they just kind of did an assessment on the way in the door of what existing mental illnesses were present. They used a structured clinical interview, and they found roughly half had an Axis I disorder. And if you look at a mental health population, you'll find that roughly half have a substance use disorder, so it's about 50-50. And this is consistent with other research. Anxiety disorders were present in about a third, mood disorders closer to 40%, and antisocial personality disorder was also quite common, again, close to 40%. We'll break these down just a little bit more. So the mood disorders, there was really an even split between major depression and bipolar, about 50-50 between the two. And we know that substance use is a common comorbidity for bipolar disorder, so this isn't really surprising. And of the anxiety disorders, PTSD was the most common that we could find. Second to panic disorder, and the other anxiety disorders were less common. So why is this? We could probably talk all day about why this comorbidity exists, but I'll highlight a few things that we know. One is that this may be self-medication. We know people that feel bad with depressed mood or with anxiety symptoms do self-medicate those. So the opioid use may be a form of self-medication for the pre-existing mood or anxiety symptoms. Clearly, there could be a shared genetic vulnerability between substance use disorders and depression or anxiety. And maybe more interesting is the role of the endogenous opioid system, which we know regulates mood. And we also know that it's dysregulated in depression. And mu-opioid receptor activation has antidepressant properties. We see this in rats, and we see this even in human studies, but there's a problem with that. And I think we're all familiar with it. It leads to tolerance, addiction, and even the risk of overdose. So we don't make it a primary intervention to address this dysregulation with mu agonists because of their abuse potential, but it has been shown to have antidepressant properties. And then the cycle of intoxication withdrawal can clearly induce depression and anxiety symptoms. So that's also part of the picture. So what are the consequences? For people that have opioid use disorder and are in treatment, they're on methadone maintenance, the presence of anxiety predisposes them to relapse. So we know even once we get people engaged in treatment, the presence of anxiety
Hey, baby.
Can you please mute your phone?
Same phone?
Thank you. Okay, so the presence of anxiety is a risk for relapse, and the higher levels of anxiety and depression lead to more polysubstance use or cannabis and benzodiazepine use, and this is true for individuals in treatment. If we look just at, I'm sorry, I don't know what's happening here. Okay, if we look just at opioid use disorder and depression, we see a greater likelihood of a history of suicide attempts, the severity of depression, poor quality of life, and overall worse treatment outcomes and more substance use. So this is consistent with what we just discussed. So here's an interesting topic, is what does treatment of opioid use disorder do for mood and anxiety symptoms? And does it have positive effects or negative effects? What's the implication? In the case of naltrexone, What we find is that there isn't any difference relative to buprenorphine, and I'll just put it out there that buprenorphine is probably the gold standard, in particular for the treatment of depressive symptoms in patients with OUD. We see this clinically, and I'll get to some research on it in a minute. So when you compare naltrexone to buprenorphine, we don't see any difference. They both actually improve scores of anxiety and depression. And this is relevant because some of the earlier concerns about naltrexone haven't really been shown out. So, the idea is if mu activation is responsible for some antidepressant effect, naltrexone, which is a mu antagonist, would lead to dysphoria and could actually cause depressive symptoms, actually doesn't seem to be true. It's not true in people with a history of opioid use disorder, and it's not true in individuals with other substance use disorders. We just haven't seen it really borne out in any research. In the case of methadone, we do see a gradual decrease in depressive symptoms, particularly after 3 months, and that might just be because that's when they started measuring depressive symptoms. It probably happens a lot sooner than that. In the case of buprenorphine, and we'll spend a little bit of time talking about this, there is a relatively robust reduction in depressive symptoms when you start somebody on buprenorphine for the treatment of opioid addiction. It seems to be as good as methadone, so there is really no significant difference between the two in comparisons. And there's also some other interesting findings that we see with buprenorphine treatment is that adherence to medications for chronic diseases, including antidepressants, actually improves. So there may be additional benefits with the use of buprenorphine for people with opioid use disorder in terms of their ability to care for themselves. So what does this mean? Well, it doesn't matter what medication you start somebody on, their depressive symptoms are going to improve. And they're probably going to improve within the first few weeks. If they have severe mood symptoms or suicidal ideation, it would be prudent to start an antidepressant earlier. If their symptoms are mild or you can connect them to their substance use, you can probably guess that they're going to get a lot better relatively quickly just with putting them on one of the OUD treatments. So a little bit expansion on buprenorphine. This was a one-dose study, so patients with opioid use disorder and either GAD or depression were admitted to the hospital and given one large dose of buprenorphine, 32, 64, 96 milligrams. And these are actually two different studies, but they were designed almost identically. What they found is on a standardized scale, depressive symptoms decrease into the minimal range within 3 days after just one dose of buprenorphine. And they also had a similar finding for anxiety symptoms. They were almost completely gone after a week. Another study using these same dosages found a reduction in suicidal ideation, and there wasn't any difference between the 3 doses. You probably all heard about buprenorphine being studied as an antidepressant. The idea is that as a kappa antagonist, it may have antidepressant properties, and just to give a little bit of background, dynorphin, which is elevated in withdrawal, causes dysphoria and depressive symptoms. Dynorphin activates kappa opioid receptors. Buprenorphine has antagonistic properties at kappa opioid receptors, which may confer its antidepressant effects. In order to separate that out from its mu activity, it was combined with a mu receptor antagonist, samidorphan, which is, it was put in a combination pill. They're both sublingually active. So you get mu antagonism along with the kappa antagonism. And this was studied. There was 3 studies. It was Forward 3, 4, and 5. That was the name of them. And only one of them met the primary endpoint. The other 2 were negative, and the FDA voted against approval for the product. This wasn't in an opioid use disorder population. This was for patients with treatment-resistant depression, and it was used in combination with an antidepressant, mostly SSRIs. All right, so we're going to transition to kind of an overview of how we address the mood and anxiety disorders in patients with opioid use disorder, with opioid addiction. In general, the data pool is very small. Most of the studies were done a long time ago, like 20 years ago. And because of that, they were largely in combination with methadone maintenance. The majority focused on depression. You'll see in a few minutes, there are actually very few that address anxiety. The good news overall is that symptoms improved regardless of what was done, whether it was a placebo that was added to methadone or buprenorphine, or if it was an antidepressant. Patients generally got better, but there wasn't a lot of separation between the two, which is why we don't have a lot of effective treatments. In our Q&A that you guys filled out when you signed up for the webinar, and there were a number of questions about behavioral interventions, and we're focusing on pharmacotherapy today, but I do want to point out that behavioral interventions are effective. In particular, CBT seems to work for both depression and anxiety symptoms. There's also some data to support relational psychotherapy and acceptance commitment therapy. They're effective, and if you have access to them, they are excellent adjunctive interventions. So we're going to talk about pharmacotherapy. And we're going to start with the SSRIs. So this is everyone's go-to when it comes to depression, regardless of the co-occurring disorder. And they've been studied extensively. We have no less than 5 studies that have been done with SSRIs, and even a meta-analysis. And you can see that on the depression outcome, there wasn't any difference. So if you add any of the commonly available SSRIs to methadone or to buprenorphine, there was no difference. If you pull all these together, there was no difference. And there may be a few reasons for that. One is that if you look at these, the doses that were used in these studies were, I would say, on the lower to moderate side. Sertraline at 170 is probably getting close to the 200 milligram maximum dose, but the rest of them are kind of in the moderate range. For citalopram along with bupropion in particular, they only use 50 milligrams of bupropion, and we go up to 400 or 450. So there's much higher doses of bupropion that can be used. As citalopram, it's almost a starting dose. So we have, kind of lower doses of SSRIs. They didn't show a lot of efficacy, and the dose may be part of it, and there wasn't a benefit as a class is concerned. All right, so what about tricyclic antidepressants? We don't use these as much anymore because the SSRIs have a lot fewer side effects, but I think it's important to look at the data with TCAs because they do look to be effective as a class, and I'll point out what individual agents are effective. The first group here, the tertiary amines, and remember these are more serotonergic than noradrenergic. They have more side effects, more sedation, more anticholinergic side effects compared to the secondary amines, so they don't have as good a tolerability. But as a group, you'll see that imipramine has efficacy, doxepin, at least on the CGI in one study, and then in 2 others, it was actually significant for all measures of depression. So there's actually 3 solid studies here with tertiary amine tricyclics that are effective. The secondary amine, which was studied with cipramine, and actually in 3 cases, they combined it with contingency management, didn't separate at all. One thing that I'll point out for both the SSRI and the TCA studies is that there was a lot of comorbid substance use. Cocaine use was very common in most of these and clearly a confounding factor to the treatment outcomes. We know that contingency management can be effective for stimulant use, and I think it was a rather ingenious intervention, but it didn't turn out to make any difference in this case. So the secondary amine dicipramine, which is more noradrenergic, did not have any benefits, but we do have efficacy with the tertiary amine tricyclic antidepressants. And again, if you combine them all together, they are effective as a class. All right, so in general, we have low to moderate dose the use of low to moderate dose SSRIs was not found to be beneficial in the research today, and there are some problems, I think, with the research. Therapeutic doses of TCAs do seem to be effective. So we do have some positive research. It is limited. So how do we put this together? Aggressive treatment, I think, is really imperative for opioid addiction. That is the life-saving intervention. So if we have somebody coming into our care, we want to first stabilize their opioid addiction. And what we know from the research is that, and even from clinical practice, that patients get better if you treat their opioid addiction. In the case of someone who may not be motivated to start on opioid addiction treatment, I think we still need to do a good job of addressing their mood symptoms. If somebody is using heroin and they're depressed, the best chance we have of engagement and improving their quality of life is to treat their depression. So we need to treat it regardless. But we have to recognize that their mood symptoms are probably going to get better if we treat their opioid addiction and then add on antidepressants for their mood symptoms. But we do want to address both of them. All right, so this is kind of my general approach to treating depression, and there are some specific thoughts in this case for the comorbidity with opioid use disorder. Despite the evidence showing favorable efficacy for TCAs, I think we still need to look at SSRIs first line, simply because of tolerability. We got a much better chance of somebody staying on an SSRI than we do a TCA. And I would even try two of them. My favorites are sertraline and escitalopram for tolerability, and they don't have a whole lot of drug interaction, so they're fairly easy to use. They're also easy to dose. We want to make sure that we maximize the dose, regardless of the SSRI that we use. If that doesn't cut it, we can switch to a TCA, an SNRI like duloxetine or venlafaxine or mirtazapine. There may be other reasons that you start with a TCA or an SNRI. So if you have comorbid pain, or if you have somebody with migraine headaches and you're looking at prophylaxis, you may actually end up using a TCA somewhat first line, or if they've already failed an SSRI, you may end up in this location. So don't rule out TCAs as being your go-to if you have other reasons to do it. There are many augmentation strategies that can be added on to medications like SSRIs, things like bupropion for sexual side effects, triiodothyronine, which is T3 or cytomel, very well tolerated. It was studied in STAR-D and picked up a number of responders. Lithium is also an excellent option. Tolerability is not as good as T3, but it is effective. And then we have quite a few atypical antipsychotics with data: aripiprazole, risperidone, olanzapine, quetiapine. They do come with some baggage of weight gain and metabolic side effects, but there's clearly an efficacy indication there. And then we get down to combinations like mirtazapine and SNRI, which was in the level 4 group of STAR-D and found to be as effective as the MAOI tranylcypromine. So these are things that we need to move to in some cases. All right, so one of the questions that came up was, what about antidepressant drug interactions? And this is always something to consider. The antidepressant that has the most drug interactions is fluvoxamine. It's a pan-P450 inhibitor, so it does have a number of them. We're talking about 1A2, 2D6, 2C9, 2C19, and 3A4, and it may increase methadone concentration in a clinically significant way. In the case of TCAs, we can see additive sedation, obviously constipation and QT prolongation when combined with methadone. And if somebody's on a therapeutic dose of methadone for opioid addiction, which they should be, that's greater than 80 milligrams, and you start them on a TCA, it's probably prudent to check their QT, particularly if they have electrolyte disturbances. Note that methadone does have serotonergic activity. There have not been any documented clinically significant interactions with antidepressants used monotherapy in terms of serotonin syndrome, but it's always a risk, particularly as you add on additional serotonergic agents on top of it. And buprenorphine is pretty clean. There isn't any pharmacokinetic or pharmacodynamic interactions that we really care about with antidepressants. All right, so we're going to talk about anxiety disorders next. And you'll see that there is a paucity of data. We have essentially 3 studies. 2 of them were pulled out of depression studies. So, and the 2 depression studies with doxepin, they looked at anxiety symptoms, not anxiety disorders, but anxiety symptoms. And they found that they improved. So there's some benefit to using doxepin for anxiety symptoms, but it's not very clean. There was a small study with buprenorphine. They, again, didn't look at any specific anxiety disorder, but it was in methadone maintenance patients, and it didn't seem to make any difference. And that's all we have. So we really are going back to how do we treat anxiety disorders? And similar to depression, SSRIs are going to be our first-line treatment, and definitely for anxiety disorders, in particular OCD, higher doses, even supratherapeutic doses may be necessary. We look at other serotonergic agents like TCAs. Obviously, the tertiary amines would be preferred. SNRIs, mirtazapine, and then we have different combinations. SSRIs with mirtazapine, and I'll just say a note, mirtazapine has got a lot of interesting properties. One is it's sedating, which is often useful. Another is it helps out with nausea because of its 5-HT2C antagonism. Third is we actually have 2 positive studies with it for methamphetamine addiction. And we haven't really found other drugs that work for methamphetamine use yet, and mirtazapine seems to be showing us some promise there. We see a lot of comorbidity with methamphetamine use and opioid addiction out here on the West Coast, so that's another reason to use it. And the SSRI and the low-dose TCA, it's not my favorite combination, but back in the old days, it was something that we did a lot for insomnia. In particular, low-dose doxepin, I think these days is useful, but you have to watch out if you get your TCA dose above 50, along with drugs like fluoxetine, paroxetine, or fluvoxamine. You have to check a level because we do get concerned about toxicity. There are a number of symptomatic treatments, and these you'll probably rely on as heavily as you do antidepressants, which are treating the underlying anxiety disorder, because we have a lot of symptoms that are concerns brought to us, in particular things like insomnia, vivid dreams, nightmares, hyperarousal, reports of anxiety, social anxiety, panic. There's a number of anxiety symptoms that are particularly problematic. And we want to have strategies to address them. Prazosin, which is an alpha antagonist, has been very effective. It does cause hypotension, so we have to start at low doses and titrate it slowly. Trazodone is probably the most commonly prescribed psychotropic drug on the planet, so everyone's fairly familiar with it. It is an effective treatment for insomnia. Again, low-dose doxepin. The commercially available doses, I think, are 3 and 6 milligrams, but we can get the generic 10 milligram without much problem through most formularies, so that's usually where we start. Guanfacine and clonidine, the alpha-2 agonists, can be very helpful for hyperarousal. And something I've learned is that clonidine in particular is something that patients use when they detox. So they're often familiar with how it makes them feel. And if they have kind of a hyperarousal state around the clock, they already know how they're going to respond to clonidine. It's something that, we can try without a whole lot of concern because they've already had exposure to it. And guanfacine is just like clonidine, it's just better tolerated. And then the gabapentinoids, gabapentin and pregabalin, which I would say are almost ubiquitous in patients with opioid use disorder. It's very common that we see people come in on these, that they've been used for pain and for anxiety and for withdrawal symptoms. So there's often a lot of experience with them, and they also can be very effective strategies for anxiety symptoms. All right, the big question is what to do about benzodiazepines. And again, this came up in the questions that you guys submitted. So needless to say, almost half of those entering in treatment have a history of benzodiazepine use. It's very common comorbidity, and it's something that we see day in and day out. It does adversely affect treatment outcomes, unfortunately. And we're all aware that the co-ingestion of benzodiazepines with opioids is a risk for an opioid overdose. So there are some definite safety concerns with this. So what do we do about it? Well, again, my approach is often to address the biggest threat, in that, in somebody that's injecting heroin, it's going to be their heroin use. So we try to address that at first. Someone's coming in, they're saying, I want help for my heroin addiction. We're in a good position to do that, to start them on, buprenorphine, methadone, and to stabilize their opioid use. That gives us the chance to then work on their benzodiazepine intake. And this may not be sequential. We may have to treat their opioid addiction and say, well, come back to your benzodiazepine use. And some of it depends on how they're using benzodiazepines. If they're binging on them and buying it on the street, that's very dangerous, and it's something we probably want to address sooner rather than later. If they have a prescription, they're taking a fairly consistent dose, maybe it's on the lower end, it's not something that we need to think about right away. Often in the case of benzodiazepine use, there is comorbid anxiety and insomnia, and we want to address that with our preferred treatments at the same time. For individuals looking to change their intake of benzodiazepine, so they say, hey, I don't want to take 6 milligrams of Klonopin every day, what can we do about it? I usually prefer to switch to a longer acting, less lipophilic drug, and chlordiazepoxide is often my go-to. And there's a few reasons for that. One is that it's unfamiliar to them, so they don't know what dose they want. And the second is that it's long acting, so there's not a lot of rebound anxiety, and that's more important for short acting drugs like alprazolam. Once we make the switch, then we'll proceed with a slow taper or dose reduction. And just as a qualifier for individuals that have been on, low stable doses of prescribed benzodiazepines for a long time, getting them completely off it may not be realistic, and it's not worth the battle. And this was been repeated in tip 63 out of SAMHSA. They said some patients may have taken appropriately prescribed benzodiazepines for years with limited or no evidence of misuse. For such patients, tapering benzodiazepines may be contraindicated and unrealistic. And I'll just add to that it's very difficult, and it becomes the focus of every interaction that you have with a patient. And under these circumstances, it really may not be worth it. So I see a question about the effects on memory, and I'm not suggesting that long-term benzodiazepines are effective or safe. But we have to acknowledge that somebody that has been prescribed a benzodiazepine for 20 years may never be benzo-free. The harm of taking them off of the benzodiazepine may be greater than the benefit. So that's just something that we have to acknowledge at that point. But yes, there are clearly long-term risks to them and a lack of, evidence. And it's similar to what we see with opioids for chronic pain. They have risks, they're not effective, but we have patients that have been on opioids for a very long time, and making a complete transition away from them is very challenging. All right, so we got a case. Try to pull all this together. And if I did my job, I hopefully told you all the answers already. So this is EW, who's a 25-year-old female. She's been stable on 100 milligrams of methadone for the last 3 years. She gets 2 weeks of take-homes from her NTP. Recently, she's been struggling with her intake of alprazolam or Xanax. She does buy them on the street, and she takes somewhere between 3 or 4 of the 2 milligram tablets a day to help her relax and to go to sleep at night. She does have a history of trauma and meets criteria for PTSD with prominent hyperarousal and nightmares. All right, so the first question is, what are we going to do about her benzodiazepine use? And I'll tell you right now, the very first thing I would do is make sure that she has naloxone in her hand. We have seen a large number of alprazolam pills or Xanax pills contaminated with fentanyl. So I'm always concerned about an opioid overdose when somebody's buying pills on the street. The second thing is we have to ask her what her goals are. She's on methadone maintenance. She's progressing. She has 2 weeks of take-homes. What does she want to do about it? And if her goal is to stop taking alprazolam, then we need to ask the next question: does she need to be detoxed from it? And let's assume that she's taking 6 to 8 milligrams a day, and she's been doing that for years. That would be somebody that I would be very concerned about withdrawal symptoms in. So we would have to detox her. We could offer her the option of prescribing alprazolam and controlling the dose, but I don't think that would go too well, particularly if she's buying it on the street. So if she was amenable to stopping purchasing her supply and to switch to a benzodiazepine that we prescribed, I would put her on something long-acting like chlordiazepoxide. I would probably use, a 25-to-1 ratio. So she would get, maybe 100 milligrams a day of chlordiazepoxide, so 25 QID. And that's a dose reduction, which is okay. And when you switch between benzos, you can often get away with that. You don't want to replace 1-to-1. You need to hit at least about 50% in order to minimize withdrawal symptoms. So we would switch her to the chlordiazepoxide and, work from there. And I wouldn't be in a hurry to do it. If she's engaged in treatment, she's showing up, she's getting her dose of methadone, we would work with her. She would get fairly short supplies of the chlordiazepoxide because, again, there are some safety concerns with it. But we would be fairly patient with how we did the taper. In terms of her OUD treatment, I wouldn't do a whole lot. I may decrease her take-homes to 7 days so that we got to see her weekly. And if she was unable to control her intake of the chlordiazepoxide, it would probably be even shorter than that. So she's on board with this. We're doing the benzo, taper, but she runs out early and it happens over and over again, or she shows up obtunded, then we would end up seeing her much more frequently in the NTP. And what about her PTSD symptoms? We're going to go straight for an SSRI, maybe some prazosin for her nightmares, and we could use an alpha-2, like guanfacine or clonidine for her hyperarousal symptoms. And I probably wouldn't do all 3 of those at once. She'd be pretty unhappy with us, but I would definitely start an SSRI and see how she does on that. All right, so that's our case. Let's see. All right, so we're now going to open up for questions. And again, I do want to thank everybody for submitting your questions when you registered for the webinar. I tried to address as many of those as I could. I know there were a lot of perinatal questions. I can tell you that as we speak, we do have a double-boarded OB and addiction medicine physician on the warm line ready to take your calls. So we can certainly address those on a case-by-case basis if you contact us directly. So with that, I would like to open it up to questions that we have.
James, this is Brenda. We have a first question from Elizabeth Ryan. If you could roll back to slide 16.
Here we are. Oops. Trying.
And we are going to unmute Elizabeth. Are we able to? Okay. All right. Elizabeth had a question with regard to the proposed mechanism. Are kappa effects dose-related without a ceiling effect?
We don't know the answer to that. This is full antagonism. It's not a partial agonist. So, you know, blocking a receptor is blocking a receptor. We wouldn't be sealing the pharmacological ceiling that we see with partial agonists, but this is somewhat different than how buprenorphine acts on mu receptors.
Elizabeth, if you're able to talk, go ahead and chime in. We did unmute you, but your follow-up was that you were referring specifically to high-dose bup, right?
Yeah, I was thinking about the high-dose bup and whether there was difference between those 3 high doses. You know, at our clinic, we tend to usually max out at 24, occasionally a 32 if people aren't feeling the ceiling effect. But wondering what the actual difference is between those 3 sort of supratherapeutic doses in terms of.
Oh yeah, I think they're all
kappa.
completely saturated.
Okay.
I think they were all overshoots. And you know, in the dose, they did some dose finding studies with buprenorphine for depression. They really couldn't find a dose that worked. They did everything from, you know, 0.2 milligrams up to, I think I saw 12 in one study, and there wasn't really a whole lot of variation in them. And what we know about buprenorphine is it's a very potent drug across its dosage range. We have almost complete receptor saturation, mu receptor saturation, you know, by 16.
Right.
So we don't really have a good idea of what's an antidepressant dose, but it's far lower than the dose that we need for opioid addiction.
Okay, great. So really nothing new that I should put in my brain about doses above 24.
Now, if you're hitting therapeutic doses for opioid addiction, then you're maximizing the antidepressant properties out at probably, you know, by 12-fold.
Okay, awesome. Thank you.
Yeah.
Elizabeth, I think you had some additional questions. Feel free to pose them, I think, while we're waiting for others to send in their other questions.
Okay, sure. So when you were going through evidence for SSRIs, it seems like, you know, if I was getting the context right, SSRIs are generally not effective in opioid use disorder for treatment of depression. A, is that what you were saying? And B, why should it still be first line if it's water?
Yeah, well, I think in these studies, they did, you know, we're only looking at 5 studies. They did not shown to be effective. And I think there's some reasons for that. Comorbid substance use, fairly low doses. There's a number of things about them that may have resulted. And it's not that they didn't improve depression, it's that they didn't separate from placebo. So these were pretty well designed studies. And we know that a number of antidepressant trials are really struggle with high placebo response rates. And I think that's part of what we probably saw in the SSRI studies. But when you package all that up, we still have to look at their relative safety and their potential benefit.
Sure.
So we have limited evidence saying that they're not effective for people with opioid use disorder, which may be for the variety of reasons I said. On the other hand, we know that these are effective antidepressants and they're well tolerated, and pretty much everybody deserves a shot at an SSRI.
Sure. I guess this segues to my next question, which is sort of I'm in the habit from my sort of pre-substance use disorder family medicine work of maxing out an SSRI if at all effective, and then my usual augmenter is Buspar. Should I just be switching to mirtazapine?
I think, yeah, switch to something else. And it might be swapping out the SSRI for a TCA or for an SNRI or something different.
Okay, as long as there's not sort of significant suicidal ideation or.
Yeah, there's a variety of concerns that come with that,
Yeah.
but there probably is a little bit more effectiveness with TCAs, and it's just balanced against less tolerability. And this isn't just true for opioid use disorder; it's actually true for other substance use disorders. If you look at SSRIs and TCAs, you see that TCAs tend to do better for comorbid substance use disorders.
Okay, and again, can you just say sort of which tricyclics you would choose? I'm not a pharmacist, and I've been going with I think there are fewer side effects. The anticholinergics with nortriptyline, but are you saying those are actually less effective?
It looks that way. I mean, you're not getting the dual mechanism out of it. So my go-to is amitriptyline, and it's what I'm comfortable with.
Okay.
It's what I'm familiar with. It's a tertiary amine, so it looks a lot like imipramine. But also, doxepin in the low dose range, I've used a lot for insomnia, and I can say that probably would be my other favorite. So, pick a tertiary amine that you're comfortable with. I think most of us actually have done a lot with amitriptyline just from pain. So that's usually a good go-to.
James, we have another question from Paul Manning. He asks, there are growing concerns regarding risks of gabapentinoids for non-approved use. Do you share these concerns?
Absolutely. I think they're overused as a medication class with very limited evidence. But we do have some for anxiety disorders, and we don't have a lot of good alternatives. I think the takeaway is if gabapentin is not addressing the symptoms, get rid of it. I think there's a lot of gabapentin that's left in place unnecessarily.
Our next question is from Mihaela, and I've been able to unmute you, Mihaela, if you would like to ask your question, which is that she has a patient that quit narcotics and bought off the streets cold turkey, now very anxious and depressed, not willing to go out of the house. Mihaela, what is your question? Why is this not unmuting?
You hear me now?
Yes.
Yes, we can.
I'm sorry. So I put this man, I'm a primary care doctor, so he's struggling with his desire to go back on the drugs. He's on sertraline 150, but he's not doing too well. Should I add some, I don't know, what should I add? Some maybe clonidine or maybe like low dose of nitrazepine?
So you have a patient who is buying pills on the street?
I didn't even know. So he quit cold turkey, but he's struggling with the desire to buy again. But
I would, your go-to is going to be to treat his opioid use with something like buprenorphine.
Okay.
Or get him into a methadone clinic. So I think part of what you're seeing is the craving and the withdrawal dysphoria.
Yeah.
That's probably driving the depression. So he's going to feel a lot better, on an agonist or an anything actually for treating his opiate addiction.
Okay.
And
thank you.
Yeah, 3 or 4 weeks of that, and then your next step would be to consider, working on his antidepressant regimen.
Okay, good. Thank you.
James, our next question comes from Donna Persaud. Can you summarize again the approach to the 3 questions for case EW?
Yeah, let's go down to that. All right, so the questions are, so again, this is a girl who's on methadone maintenance. She's got 2 weeks of take-homes, and she's been buying Xanax on the street, and she's taking 6 to 8 milligrams a day. She also has comorbid PTSD symptoms. So what are we going to do about her benzodiazepine use? And the first thing is we're going to ask her what her goals are. nothing in this case actually tells us what she wants to do. Assuming that she's interested in stopping her intake of alprazolam or buying it on the street, we would need to assess her need to complete a detox, and she's been taking it for a number of years. We're going to have to medically detox her with a benzodiazepine. We would convert her to chlordiazepoxide at roughly 50% of the equivalent dose and do a slow taper on that. For her methadone maintenance, we would decrease her take-homes to weekly or even less so that we can keep a closer eye on her while we prescribe her chlordiazepoxide. Her PTSD symptoms, well, we want to start an SSRI, maybe a prazosin for her insomnia. And we could also use an alpha-2 agonist for her hyperarousal symptoms.
Our next question is, what is the safest dose of gabapentin to prescribe for pain for a patient that is prescribed buprenorphine?
I like to keep it within the 1,800 milligram a day range. I don't think that there is a clear cutoff between a safe and an unsafe dose. But in general, I'm concerned about sedation, which becomes problematic when you get above that. And that would be 600 TID, kind of on the upper end of the spectrum. Clearly, less is better. And for patients without a lot of CNS depressant use that haven't used benzodiazepines or alcohol in the past, even 300 milligrams can make them overly sedated, in particular in combination with buprenorphine. So it really depends on the patient.
I do believe that is the last of the questions related to your presentation. I'm just wondering, I wanted to maybe just take a moment, while potentially some more questions come in, just to thank everybody. Our project is supported by the Health Resources and Service Administration, and we are the Clinician Consultation Center. We provide free clinical guidance to healthcare providers nationally across 6 different services. Dr. James Gasper is one of our substance use warm line consultants, so you would be able to speak with him if you had any specific substance use questions. If you were to call our substance use warm line, we have a team of experts in addiction medicine that are board certified, and as James mentioned, we also have someone that is also double board certified in OB-GYN as well as addiction medicine that are available to answer your calls. In addition to our substance use warm line, we also have a perinatal HIV hotline, an HIV AIDS warm line, a PrEP line, a hepatitis C warm line, and a PEP line. To learn more about these services in terms of the types of questions that we're able to answer, as well as to learn more about our program, our free program that's available to healthcare providers, please visit our website at nccc.ucsf.edu. We also want to remind everybody that there's also technical assistance resources that are available, such as the HRSA Bureau of Primary Healthcare Substance Use Disorder and Primary Care Integration webpage, the HRSA Behavioral Health and Primary Care Integration webpage, of course, as I mentioned, our substance use warm line. There's also NIDA's, National Institutes on Drug Abuse. There's screening tools for depression, drug, and alcohol use, bipolar disorders, suicide risk, anxiety disorders, and trauma through SAMHSA, and the Agency for Healthcare and Quality Academy for Integrating Behavioral Health and Primary Care. Please feel free to spread the word about what we do. We will be sending out a recording as well as a copy of our slides at the conclusion of this presentation. We want to thank everybody for joining us, and we want to particularly thank HRSA Bureau of Primary Healthcare for co-hosting this event with us. And of course, a giant thank you to Dr. James Gasper for his presentation today. Do we have any last questions before we conclude our webinar? All right, well, thank you everybody for joining us on a late afternoon and on a Wednesday. We wish everyone a great day and we look forward to receiving your calls. Thank you so much.